everybody. I'm Maria Dall'Era, Professor of Medicine and Chief of the Division of Rheumatology at the University of California, San Francisco. And I'm joined today by Liz Lightstone, Professor of Renal Medicine for the Faculty of Medicine and Honorary Consultant Physician, Imperial College London, Hammersmith, UK. Hi, Liz.
Hi, pleased to be here. Today we've done a webinar which you can go and see on the Lupus Forum, but we're going to provide highlights of the content discussed today, the 14th of May, and it was chaired by Professor Ed Vital and included presentations from Professors Brad Rovin, myself, and Maria. And the topics we covered were standard of care, current standard of care, its practical application in clinical settings, future treatment pipeline, emerging therapies with particular focus on obinutuzumab, and personalized treatment strategies for lupus nephritis. If you want to see the whole thing, move to the on-demand webinar and detailed discussions from individual speakers. You can see it on www.lupusforum.com and watch for free. I'm just going to briefly overview what Brad was doing, but I'm interested to hear, Maria, what you took away from his talk. He gave a really interesting, almost historical overview of how we got to standard of care in lupus nephritis and the relatively recent guidance, which has since changed. And he talked about the goals, what we're trying to achieve in lupus nephritis. And the ultimate goal is to preserve kidney function, but we want to treat people to minimize toxicity, live healthy lives, and preserve their nephrons over time. And the background to all the treatments that we've been using, he highlights, was steroids, and they have multiple effects on all the pathways, if you like, that are involved in lupus nephritis. And he went into some detail about those pathways. He also presented, I thought, some really interesting data on the bits of the biopsy that respond very rapidly to steroids, such as presence, but actually how things like endocapillary hypercellularity respond much more slowly. He talked briefly about MMF and cyclophosphamide, the history. Remember, we started with high-dose cyclophosphamide, the NIH protocol. MMF came in after really the ARMS trial, which was not a positive trial for MMF. It was interpreted as MMF not being inferior to cyclophosphamide, but it was set up to show superiority, which it did not do. But because MMF doesn't have the effect of causing infertility that high-dose cyclophosphamide often did, it became the preferred approach. And there were guidelines from KDIGO, which is Kidney Disease Improving Global Outcomes, in 2012 and updated in 2021 that said to use MMF or cyclophosphamide as your starter, and you moved from high-dose cyclophosphamide to the Eurolupus regimen, which was much lower dose cyclophosphamide, and which had shown benefit, but in quite a narrow group of people, in the sense that the studies were in mostly Northern European whites, and showed that these were essentially equivalent. Brad then presented some really interesting data about the placebo arms of various recent trials. Remember, the placebo arms aren't placebo. They all get either MMF and steroids or cyclophosphamide and steroids, and usually low-dose cyclophosphamide. And he looked at the LUNA trial, the Belong trial, the Eurolupus trial, the Access trial, and the other arm of the Eurolupus trial, which was high-dose cyclophosphamide, and showed that actually at 12 months, the complete response rate was on average, using MMF as your standard of care with steroids, 35%, and using cyclophosphamide was 34%, so no different. But what he also highlighted was the importance of achieving complete renal remission. And he showed data showing that if you achieve a complete renal remission, you are far more likely to have preserved kidney function long term than if you achieve a partial remission, and even more likely with partial remission than if you don't achieve remission. But the patients with only partial remissions and those with no remission are much, much more likely to end up with end-stage kidney disease. Remember, these are young people, so this has a really major impact on mortality as well as morbidity. He also talked about flare rates, which on average in placebo arms of recent trials, the Regency trial, the Aurora 2 with voclosporin, and the Bliss LM with belimumab, were around 25 to 28% of flare rates. over varying time points from 1.5 to 3 years. So they're very high flare rates, and they involve increased exposure to immunosuppression to treat the flares and increased chronicity on biopsies. So that's bad. But what he really highlighted, and which is not music to my ears because it's so depressing, but it's really important, was data showing if you look at how patients fill their prescriptions, the majority of patients, 45% of patients, are not taking their tablets, whether it's azathioprine or MMF, by I think it was 2 months after starting or 3 months after starting therapy. And a minority of patients, 16 to 18%, were actually continuously taking the drugs they were provided with. And if you don't take the drugs, they don't work. And we need ways of reducing pill burden, improving adherence, which is a really complicated thing to do. And Maria, I know you've done a lot of work in this, and I'm interested to hear your views. And he talked about the benefit of monitoring drug levels. And we use hydroxychloroquine drug levels because hydroxychloroquine is a very long-acting drug and is really good. You can't say, I just missed one pill if you have undetectable hydroxychloroquine in your blood. You really aren't taking your medications. Anyway, that's a sort of rather long synopsis of Brad's talk, but I wondered what your takeaways were, Maria.
Yeah, that was wonderful, Liz. Thank you for that excellent summary of the highlights. I think, what's interesting is as I reflected upon Brad's talk, where he beautifully reviewed our conventional standard of care therapies and kind of the evolution of therapies, right? From high dose NIH style cyclophosphamide to MMF to the urolupus cyclophosphamide, how we use glucocorticoids. It strikes me that in order to understand where we are at the current time in terms of our evolving paradigm, there's a benefit of looking back, isn't there, in understanding how we got to where we are now and why we are doing what we are now and why the recommendations have changed. And that is because despite these excellent, potent immunosuppressive therapies, we still are seeing unacceptably high rates of end-stage kidney disease, LN flares, intolerance to medications, difficulty with adhering to medications, incomplete rates of renal response, right, at 6 months, in 12 months. And we needed to do better. And hence, the recommendations have now evolved. And this will get into, I think, the next two presentations. The evolution to now be using combinations of therapies, which we've termed this triple immunosuppressive approach, glucocorticoids and 2 additional immunosuppressive agents, to what we hope to be able to effectively treat lupus nephritis and mitigate some of those problems that Brad so beautifully highlighted in his presentation.
I agree. And I think, in trials, you do assume that everybody's taking what they're taking. I've always had this slightly cynical view that one of the reasons belimumab did so well at 2 years, because the BLISS-LN trial had a 2-year endpoint, was possibly by the time you got to 2 years, the only drug they were taking was the IV belimumab because that was supervised and given. But that's a very cynical viewpoint. But adherence is a major problem. And I think, people have busy lives. I take some medications, but I'm useless at taking anything more than once a day. And MMF, we really need something that replaces a twice-a-day drug, I think, because I think it's really difficult. These are young women. They have, they've got young kids. It's just, we're very critical of our patients, but it's not easy. And we need to support them better. And I think that segues nicely into your talk, which I hope you're going to summarize, because you talked about the need for a holistic approach.
Yeah, so thanks. So then I then followed Brad by talking about our new approach and the new recommendations from the ACR. And Liz will also, I'm kind of previewing her talk where she talks about the British Society for Rheumatology recommendations as well, which are hot off the press. But both of these societies are recommending triple immunosuppressive therapy. So the notion that instead of the traditional way of doing things, with an induction or initial phase and a maintenance or a subsequent phase. Instead of that traditional approach, we've now evolved into using continuous combinations of therapies, triple immunosuppressive therapies. But the important aspect of all of this is that we want to treat the patient and the kidney in a holistic way. And when we think about the mechanisms of injury in lupus nephritis, we think about the immunologic mechanisms, which are addressed by our immunologic therapies, or this triple immunosuppressive therapy approach. But we also have to think about the other mechanisms of progression of chronic kidney disease and how we can impact those mechanisms. How can we decrease hyperfiltration, ongoing nephron injury and nephron loss by mechanisms that are not directly related to ongoing immunologic activity? And that is where medications such as the SGLT2 inhibitors, of course, the renin-angiotensin-aldosterone system inhibitors, the MRAs, perhaps the GLP-1 receptor agonists are going to come into play. But we still need more data on, for example, the SGLT2 inhibitors and the GLP-1 receptor agonists to understand where they're going to fit in. Because as you so beautifully said, Liz, even with our immunologic therapies, it's impossible to take all of these pills. And now we're adding even more medications on top of that. So we have to be smarter and gather more data to understand how we use these medications at which phase of their disease, so we don't completely overwhelm our patients such that nobody can take any of these regimens. And that is going to be our next, I think, important job. And actually in the discussion or the Q&A part of this podcast, which was a lot of fun, Brad talked about a study that he's doing, right, where he's combining belimumab, voclosporin, and MMF. One group is getting those three therapies, and then the other group is also getting those three therapies, except their MMF is getting taken off at 3 months. So thinking back now, this paradigm where we're starting with combinations of therapies that are targeting different immunologic mechanisms, but then peeling back to make the regimens more practical and doable for our patients. Whereas the old model was you start with one drug in addition to glucocorticoids and you build as people are not doing well. We flipped the model and now we're saying start with combinations, but how do we then peel back, right? How do we start to think about peeling back? And Liz, you did this. You were the pioneer with this, with your rituximab trial, where you were parsimonious and you used anti-CD20. Back then it was rituximab and MMF, no oral steroids, but that was already, I think, a more efficient, practical regimen. So you've already done this. You've pioneered these regimens.
So we're doing it. We're currently writing up our 20-year experience of using rituximab and as I showed in my talk, it's 23 years since someone else, not us, showed that rituximab likely worked till we got a phase 3 study. But we've been using B-cell depletion for years, and we really have minimized steroids. And the funny thing is, that's why I think looking back is important. I've forgotten what the Cushingoid patient looks like until I put them in trials, because nearly all the trials require quite high dose steroids compared to what I normally give. And I am reminded because I had 2 patients in one trial recently, and their constant refrain was, please can I get off steroids, please can I get off steroids? And they did very well. And I think what we shouldn't forget is if you give enough steroid and enough cyclophosphamide, patients do pretty well for quite a long time, but it's such a cost. When I first started lupus, I made everyone amenorrheic. So with the high dose cyclophosphamide, we don't see that now. We give ovarian protection, we give lower doses. But I think you very nicely summarized in your talk the BLISS-LN data using belimumab on top of MMF, and there's data there with cyclophosphamide, and the Aurora study using the voclosporin. I think what's nice is you then said, well, think about the patient in front of you. In which scenario would you favor you would use one of those drugs? And you talked about the ACR guidance, which now says triple therapy, and sort of pure class 5 uses CNI. Generally, voclosporin, when their GFR is better, they're more proteinuria, because you show data showing a very rapid response of proteinuria because of the effect on the podocyte. So I think that's really important. And again, I hark on, guidelines are just guidance. They're not set in stone. And you have to look at the patient in front of you and what's happened before and what they've responded to before and knowing what they're likely to take. Once you get to know them, I've got patients who just won't take a tablet and who really like intravenous. Coming up once a month for a drug suits, and Pat's coming up for obinutuzumab every 6 months. That's fine. And they'll forget about their system. No one's recommending single therapy yet, but it may come. We need the data.
Absolutely. I think that's a great segue, Liz, to your presentation. If you want to finish with your presentation, I thought yours was very enlightening with the use of the new therapies, the new B-cell depleting therapies, and you went through some of the exciting data with the cell therapies with CAR T and some of the initial data on the first 5 patients and then the first 8 patients showing these extraordinary results and early complete remissions off therapy. And then you spoke about the bispecific T-cell engagers and what role those might have. And we have less data on those, but the data are coming. And then the new anti-CD20 obinutuzumab, which is the glyco-engineered humanized anti-CD20 with better peripheral and tissue B-cell depletion than rituximab, which we've used in the past. And you show data from Nobility, the phase 2 trial, showing excellent results. And then also now the Regency, which is the phase 3 data with the primary endpoint at week 76 and showing excellent results in terms of renal response over placebo. And it's not truly placebo, right? Because the regimen was obinutuzumab, 2 doses in the beginning, 2 doses again at 6 months, and then either 1 or 2 doses at week 52, but all on a background of mycophenolate at a dose of 2 to 2.5 grams a day and glucocorticoids with a fairly good taper, right? I think they had to be down by 12 weeks to 10 milligrams or so. Is that
Something
right?
like that, 5 milligrams by 24 weeks. And then they were maintained on the 5 milligrams. I actually think that was a missed opportunity. I'd have liked to see, because I think you probably could withdraw the steroids in the OB arm. And we don't know that. And I don't know. I don't know. There's what's really nice about the Regency study is there's a very prolonged blinded follow-up beyond this primary endpoint. And I think that's going to be hugely informative, because what didn't come out as positive in the secondary endpoints was the difference in GFR. So they met their primary endpoint, which was complete renal response, not as good as in Nobility, but still I think around 13-14% delta. But and they reduced, getting down to more patients in the OB arm got down to 7.5 or less of steroid, and they reduced their proteinuria. But there wasn't this positive difference. There was a difference in GFR between baseline and 76 weeks, but they don't have a GFR slope yet. And I think over time they will show benefit, but we don't have that, which meant that the data on flares and renal events can't be counted as significant. But there were huge differences. So just as Brad had shown in the old data in the placebo arm, there was a 23.5% rate of flare by week 76. In the OB arm, that was reduced to 11.1%, so 56% reduction. And in the unfavorable kidney outcomes, which was death, doubling of creatinine, and treatment failure, it was reduced from placebo arm from 21.3% to 8.1%. So a 63% reduction. So that's impressive. Mm-hmm. There were more adverse events. Mm-hmm. And as I reminded the audience, this was done during the pandemic and right at the beginning of the pandemic. So when nobody had any immunity, they were facing a brand new infection. A lot of these patients were from Latin America, so relatively late to get vaccinated. And if you B-cell deplete and you meet a new plug, you're not going to make as good response. But actually, overall, if you take out the COVID-related events, which reduced over time as more and more patients have been vaccinated before getting OB, those differences became less marked. But there were more adverse events in the OB arm, but nothing much that would make you think you shouldn't be giving it. So I think it's really promising data. I think the long-term follow-up will give us data on GFR slope, will give us more data on preservation of kidney function tolerability, and they're keeping it blinded, except for the patients who didn't respond, who can go into an open label study. So I think that'd be interesting, but I would have liked to see them allow them to stop the steroids, because it's a missed opportunity, and hopefully they can in the next bit.
And then I'm thinking, I think after listening to your presentation, it made me think, again, these different agents that target B cells and likely different B cell subsets, right? Depending upon what antigen we're targeting, whether it's CD19 or CD20 or some of the BCMA targeted cell therapies, and to think about which B cell subset needs to be targeted in a particular patient, how to choose among these different options. I think it's going to be quite fascinating. And that reminds me also of one of the comments that I think Brad made in the discussion as well after your presentation, which is we're going to have some repeat kidney biopsy data from OB. So are we going to see faster immunologic responses in the kidney, histologic responses in the kidney? That's going to be very interesting, not just proteinuric responses, but what's actually happening in the kidney. Are we going to see B cell depletion in the kidney? Reductions in immunologic activity. I think that's going to be fascinating. So thinking about how to position all of these therapies. One question I had for you as well, Liz, I would love your opinion on is, in the clinical trial setting, so let's just take Regency, we have to have a very standard protocolized way of giving these therapies. But in the clinic, do we really have to be giving all these multiple courses of anti-CD20? So do we have to give 2 at time, 2 at 6 months again, and then 2, because I do worry about the long-term risks of, for instance, hypogammaglobulinemia. And I think, can we get away with maybe giving fewer doses? This is a theoretical question, but fewer doses, but then following our patients carefully for B cell repopulation. I think there's some wiggle room there. Don't you agree with how
I agree. And I also think it'll be partly driven by cost. But if you think about the equivalent of vasculitis in the main Ritson trials, you could certainly do so that the main Ritson studies, as far as I remember, compared fixed dosing with dosing according to B cells and ANCA. Now, I don't think our biomarkers are quite as good in lupus. If you've got someone who reliably pops up their double-stranded DNA, drops their complement, fine, you'd think about redosing them and when their B cells come back. But we know from our Rituximab data and our Rituxi rescue, there are patients who replete their B cells who never flare. But that's partly because they are taking their MMF and they're maintained. There are other patients who, as soon as their B cells come back, but you have to sort of get to know your patients. So yes, careful follow-up. We never discharge our patients. I'm sure most of us are not going to end up giving quite as much OB. It depletes for a very long time. And actually, the ability study showed that 18 months later, they were still doing fine. Thank you very much.
Right. You showed that beautiful at week 104, right? Even though their last OB was, I think, at month 6, right?
6 months. And at week 104, they were still improving. So, and I think there will be patients, and patients vary in their kinetics of repopulating. So I think if they remain B cell deplete, again, you might refine it. And there are some patients who only pop back naive B cells, and they're probably, which we don't look at routinely, but they probably do fine. And there are patients who pop back, they're much more activated and memory cells, and they probably need redepleting. So I think we have to refine what we're doing with how we look at patients and how we follow them. But it's all going to require very careful follow-up. But I'm sure people are going to spread out their dosing. I'm sure of that.
Well, Liz, I think this was such a wonderful discussion, and it's such a pleasure and honor to be here with you today to recap the webinar. And I encourage all of our listeners to take the time to listen to the webinar. You can listen to it on your commute into work or when you're doing your exercise or whatever, but I think it's going to be well worth your while. I had a lot of fun, and I learned a lot from listening to you and Brad, and I look forward to future webinars.
Thank you. I agree. And can I just add one thing, because I forgot to mention, I mentioned the British Society of Rheumatology guidelines, which are the latest guidelines. And they mentioned, we agree with triple therapy, like the ACR, but we added an OB as a choice. Not that it's been licensed yet in the UK, but we're hoping it will be. But I think that's the future is definitely triple therapy to start with. And then, as you say, all the other things. But it's been a real pleasure discussing with you. Thank you.